Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Paige Fox, a plastic surgeon and associate professor at the Stanford University School of Medicine, discusses sustainability and environmentally friendly practices in the operating room. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Thank you very much to everyone, and thank you to Laura for hosting me. I want to thank you. I'm so excited to be here. We are sorry about the technical difficulties coming from Silicon Valley. That's a little embarrassing, but it is a Mac PC problem, so Silicon Valley would be okay with it. So today we're going to start with a quiz, because everybody likes a quiz at 7 in the morning. What is this? Anyone recognizes? It's Canadian. Gem Lakes. Okay, let's try another one. Maybe easier. This one? Yeah. Thank you. Thank you for pronouncing it. I would have slaughtered that, so thank you. This one is much harder. Anyone? This one's in California, not in Canada.
Big Sur.
Oh, I'm going to give you credit for Big Sur. This is slightly north of Big Sur, but it all looks the same. This is Half Moon Bay. Very good. So why would I bring up pictures of nature? Because that's really what this talk is about. We like these things and we want to preserve them, and we actually play a role in that. So how are surgery, the operating room, and the environment connected? And that's really through 5 different things: greenhouse gas emissions, energy, waste, water, and chemicals of concern. Now, it's okay if you don't have a background in any of these things. We're going to go over them all briefly today, and hopefully you'll know a little bit more. And that really gets me to my disclosures. 1, I love the environment. I'm excited to be here. Saskatoon is beautiful. Canada is beautiful. And I don't have all the answers. I'm not going to be able to answer every question today. I'm not going to be able to give you a solution to everything. I just want to get us on a pathway moving forward. So here's the overview. We're just going to walk through a day in the OR, since everybody here is in the OR in some way, or plays a role for the OR. And then we're going to do some case examples of things that we've done at Stanford, myself and my colleagues. And then I want to end with things that you can do starting today. So first, let's talk about greenhouse gas emissions. This is really the picture I get in my head when I think greenhouse gas emissions. This is what I think of as going on outside. But let's talk about what that is in the operating room. So anesthesia. Do I have some anesthesia colleagues in here today? I think I do, right? So anesthesia is where our greenhouse gases come from in a large part in the operating room. So only 5% of inhaled gases are metabolized, and 95% that are delivered to the patient are not metabolized, and they're actually removed by the OR ventilation system. And then we ask ourselves, where do they go? They just go out into the environment. They're just directly released off the top of the hospital through a filter, and that's it. It's kind of interesting. We don't break them down. We don't try to trap them. We don't anything them. They just go. And that actually has a huge impact. So this is a study looking at 3 different hospitals, 2 of these in Canada and 1 in the United States: Vancouver General Hospital, University of Minnesota, and John Radcliffe Hospital. And this is looking at 3 different anesthetic agents: desflurane, isoflurane, and sevoflurane. And John Radcliffe Hospital, I'm going to draw your attention to them. They did not use any desflurane. And then they looked at their environmental impact. So the volume purchase is on the left and the environmental impact is on the right. And what you can see at the end of the day, John Radcliffe Hospital had 1/10 the environmental impact of their colleagues just by switching from desflurane, just by switching away from desflurane. So why is desflurane a problem? Well, desflurane, it's more expensive. It has a much higher CO2 impact. It stays in the environment a lot longer, for 14 years, versus sevoflurane, which has a similar anesthetic effect, but breaks down after a year. So if you're in the OR running sevoflurane, it's like driving half a Hummer around your OR the whole time. But if you're using desflurane, it's actually like driving 12 Hummers around your OR. So not only is the OR very crowded, but you are knocking off the environment in a very serious way. So anesthesia is really important. I couldn't do my job without it, but there are times where we may not need an inhaled gas, right? And so that's our job as surgeons and anesthesiologists to talk about, can we do this without an inhaled gas? And so, regional anesthesia and spinal anesthesia are great options. I'm a hand surgeon, and I will tell you, I do probably 90% of my cases under regional anesthesia or local anesthesia, which is awesome, really cutting down our ability to do our environmental impact while continuing our ability to do surgery. So let's talk about water. We're all responsible for water use in the OR. So from every instrument that we choose to washing our hands before and after every case, we have to use water, right? But can any of that water be saved? Well, the answer is yes. There's a couple different options. One is just how you wash your hands. So we were all taught that 2-minute scrub, leave the sink running. That's a crazy idea if you have a drought or you have wildfires and you need to divert that water somewhere else, right? So just turning off the water actually has a huge impact. You run 6 liters of water in a 2-minute scrub. You could use a alcohol-based hand scrub, or you could just turn off the water while you're scrubbing in. And this simple idea that we can do in the operating room, we can all do at home when we're washing our hands or brushing our teeth. So it extends in every facet of our life when we think about water. The other thing for all our surgeons in the room is thinking about every single instrument we open. This has a huge impact. Every one of those instruments has to be washed, and every one of those instruments has to be steam sterilized. So my suggestion is not that we don't use the instruments we need, but my suggestion is just say, hold on that tray. I'll tell you if I need to open it. And that will make a huge impact in your in the amount of water that's getting used for each of your cases. The next is waste. Waste is really where we all are playing a part. And while we're not using plastic water bottles in the operating room, hopefully, we are using a lot of other waste. This is an example outside of my operating room before the OR day has even started. The trash can is already full, and we were using some plastic water bottles. And these yellow positioning foams, which actually come from plastic and oil, are stacked up. And this is before the day has even started. By the end of the day, we'll fill multiple trash cans and all those foams pieces will be gone. So we need to ask ourselves, do we need to create all this waste? And for anesthesia, we think about all of the plastic that we use, from every IV that we choose to hang to every medication that we deliver, from every syringe pump to every IV line. So it's not about not using them. It's about thinking about how we're delivering them and when we can use them and when we don't need them at all. So we'll give some case examples of that. The other thing here is blue wrap. I don't know, do you guys have blue wrap here? Yeah. So this is actually made of plastic too. And so every time we choose a set that is wrapped in blue wrap, we have a big impact. So again, if we just set that set aside and say, I'll open it if I need it, we can decrease our use of blue wrap. There's also a lot of companies that are recycling and reusing blue wrap and turning it into something else. So that's another option that we can think about. So waste is really complex, and I don't show this slide so that you understand how the landfill works at your hospital. If you've never toured the dock of the trash at your hospital, it's actually a very educational experience. As the medical director, I got to do that one day, and I was like, wow, I had no idea, right? So these are all the different types of trash that come out of the operating room and where they all go. And really the important thing to realize here is it's the decision point. When you place the trash in whatever receptacle is the only place we can make a difference. So the people down at the trash dock don't reopen the bag and say, oh, this is a recyclable. Oh, this is a biohazard. Oh, this is regular landfill. That'll be totally unsafe, right? So it's us, the end line users, or the frontline users, that really make the difference here. So it's really about appropriately sorting your trash and taking that extra second and saying, which one does this go in? And then putting it in the right one. And so there's also a huge cost to waste. And these are examples from our Stanford costs, but I'm sure the costs are similar wherever we go around the world. And what you can see here is that our hazardous pharmaceutical waste is the most expensive in cost per ton. So for example, if we are opening a 100 cc vial of propofol and we only end up giving 10 cc's of propofol, not only was there the impact in making the propofol, which is actually pretty impactful, but then in disposing and getting rid of that extra medication is also really impactful. So as we think about dosing and what we need on a day-to-day basis, we can really start cutting down costs. And you know who likes us to cut costs is our hospital systems. So as we want to partner with them and do projects that we think we can make the impact of surgery lower, we can say, hey, you should invest in my project because I'm actually going to give you some return on that dollar. So I'm really lucky at Stanford to have a sustainability program office. They started this 4 years ago, and it's been a great opportunity for us to get together as a healthcare system and think about these changes, both on the front line, on the back line, and then really behind the scenes. So we had to get everyone on board, and this is really difficult because people have a lot of things to focus on. And so what we did was we partnered with the School of Medicine and the hospital and said, let's get you guys to agree that sustainability is important. And then let's actually put it in the hospital plan. Let's make it one of the goals that we have to achieve as a hospital system, because that's really the only way we get buy-in across the board from our administrators, our surgeons, our nurses, our scrub techs, everyone across the board, is if we're all united in this. And so we have 5 pillars that guide every project. Before we do a project, we say to ourselves, which one of these pillars are we going to impact? And you can see these match the 5 things I told you about earlier. And then I got a couple bosses there that help us run this. And I have a co-medical director, Praveen Kalra. He's an anesthesiologist, and I'm going to talk a little bit about some of his work here going forward. So I want to just give you some tangible examples of things that we've done in our operating room that maybe you can think about for your operating room. And I know things may run differently across different hospital systems. So these are just ideas to get you started thinking. So first off, we built a hospital, and in that hospital, we built sensors over every OR door. And actually, these are very basic sensors. If you have a light at your house that turns on and off when you come into the garage or leave the garage, this is the exact same sensor. It's not it's something you can put in aftermarket. You don't have to build a new hospital to put it in. But what we have is 1 at every OR door, so 2 per OR. And in the OR, you have to have 20 air changes per hour when you're operating. But when you're not operating, you only need 6 air changes an hour. Well, on a Saturday night when I'm replanting a finger, I can tell you how many people are operating. There's like the cardiac surgeons and me, and we have 56 ORs that are changing their air over 20 times an hour. Well, that's crazy, right? So we did a little project where we said from 6, because everyone's nervous about this project, I said from 10 p.m. to 6 a.m., we're just going to turn the air handling down, right? We want the temperature to be okay when we start at 7 a.m., and we want the air cycles to be okay at 7 a.m. So just from 10 to 6, we're going to turn it down. And then we're going to use those sensors to say, is someone actually operating in that room? And that's what we did here. And you can see people come in and clean, and the air and the sensors detect that, and the power goes back up. And that's probably unnecessary. So that's probably something we can figure out. But you can see from 2 a.m. when the cleaners are finished all the way till 6 a.m. that really there's very little power being used in the operating room. This just makes sense, right? It's just like turning off the light when you leave a room. And so just doing this in 12 ORs for 1 year knocks 5 houses off the map. It's the same energy use as 5 houses. And this is simple. So this has been a great project. We're looking to roll this out across lots of our hospitals. And really, we have certain hospitals that are outpatient centers that are not used at all on the weekends. And so from Friday at 5 p.m. till Monday at 6 a.m., you could have an entire weekend when you're not running any power. As I said, I was going to talk about my colleague, Praveen Kalra. He's been really invested in looking at nitrous oxide. And so nitrous oxide is an interesting gas. It's like it was used in low volumes, but we've always purchased it as a hospital system in high volumes. Nitrous oxide is interesting is we buy it in high volumes, and it's not a very expensive gas, but we put it in this really big tank that you see on your upper right there. And then we pipe it centrally through the hospital system. And that's very common at all the hospitals across the United States and probably in Canada too. But the thing is, the nitrous oxide, because of the way it's a compressed gas, it actually leaks into the walls of the hospital. And only 5% of it actually gets delivered to the back of the anesthesia machine. And the rest of it is leaking out throughout the hospital, which is totally weird, right? And so what you can do is switch from this centrally tanked nitrous, get rid of the pipes in the hall, deactivate the pipes in the hospital, and then you can just move to these smaller E cylinders. And so we've done that. We piloted at just one site, and here you can see the impact. So these 4 different colors are 4 different sites. And then on the left side, you see what the baseline use of these was. And on the right side in that graph where you can barely see it, you see what's the current use. And that's all we didn't ask anyone to change their practice. We just said, all we're going to do is deliver it directly to the back of the anesthesia machine instead of having it delivered through a huge central tank. And so that's the kind of impact that doesn't even require a change in practice. This is just where we partner with our engineering colleagues to make this happen. And this is a cool project because see that giant orange line? That is all nitrous oxide use. And so when we stopped using the centrally piped nitrogen, that orange line almost disappears. And that actually helps Stanford meet its 2030 goal just by converting to portable E-cylinder tanks for nitrous. One single change. We met our 2030 goals, and now we're moving towards our 2050 goals. So an anesthesiologist led this entire project and partnered with the engineering team to make this happen. And it's just been a huge success. So these are from the American Society of Anesthesiologists. These are their recommendations because we talked earlier about anesthesia overall. So decreasing your use of desflurane and then thinking about nitrous oxide, how that's getting to you. Using the lowest possible fresh gas flow, using regional or IV anesthesia when appropriate, and then using those portable nitrous canisters. I also think I personally am responsible. So one day I looked over at my own trash. As Henry mentioned, I am a hand surgeon. So I do high volume, small procedures. And I looked at some of these small procedures that we sometimes do 100 of in a year. And we had 3 bags of trash after every case. And I said, this is crazy. So I partnered with one of my residents. She's Ruth Teblin. She's up there on the right. And then these are all my hand surgery colleagues. And we looked at that big pack that comes with all the single-use plastic pieces. And we said, what can we take out of that? And these are all the things we took out of that. I mean, first up at the top there is a 5-liter plastic basin. I'm doing a trigger finger. I don't know if you guys know that's a 1 centimeter incision. I could never put 5 liters of anything through there. So we just did things that made sense and got rid of them all. And this is what our set ended up looking like. And just to give you an idea of what we looked like ahead of time, our standard setup was on the left and our new setup was on the right. And due to some work from Don Lalonde, and he's actually in Canada on the eastern side, we were able to get rid of gowns for these cases. They're really minor procedure cases. And we were able to just switch over. We also started using a smaller instrument tray, and that makes difference from water and steam use. And then we rolled this out. We were able to save $70 per case. And our hospital actually has, we said to them, we're going to save you all this money. And they said, okay, we'll split it with you. And so we were able to actually reinvest some of that money back into our division and department for educational and research missions. And so these are 2 of my colleagues doing that surgery in the new state here without all that extra draping, all that extra plastic. The next thing that we worked on is something called preference card optimization. So, when you get to the OR, you want all your instruments to be there. You want them all to be ready to go. We are not patient people as surgeons. And so having the right things on your preference card is really important. So this is a picture of our preference card. Do you guys have something that looks similar where cases are pooled? So this is really where we partner with our supply chain. We all want the right instruments available at the right time. And this is how we tell them what we need on a daily basis, whether it's single-use plastic items or your instrument trays that are coming up. And this is, the OR is responsible for 30% of the waste throughout the hospital. That's not just at my hospital, but that's throughout the world. And so we went and looked at these cards and we said, can we get surgeons to look at their own cards and say, yes, I need this. No, I don't need this. Because this has been something that's traditionally been run by nursing or scrub techs. And so we asked the surgeons to do it. And we had to partner with a lot of people. And this is what I think is really important here. Anytime you want to make one of these changes, it's not just the surgeon, right? You've got nurses, scrub techs, you've got administrators, you've got supply chain, and really partnering with all those people, you get the best ideas. And so I've partnered with 14 surgeons. We looked at their top 3 to 5 cards, the ones they use the most frequently. And then we had them update their cards. We asked for their feedback, and then our goal was to scale it across the enterprise. And so in 1 year, we optimized 41 preference cards. Those cards were used over 866 cases, and we saved $200,000 in just those 14 surgeons, with an estimated cost savings of $229 per case. I'll tell you, some surgeons looked at their cards and took off a single item that was worth $900. It was being opened for every case. And the surgeon said, I don't use this. I've never used this. And I've been here for 5 years. And so you can also look in retrospect and think about how much waste and money we could save. So one example I want to give is my breast surgeons. So my breast surgeons mark every lumpectomy site with this single-use Liga clip. They use 4 Liga clips to mark, the 4 boundaries of where they took their lumpectomy site. This clip applier holds 25 or 50, and it costs $200. And then what they did was they said, we only use 4 clips. You can get this tiny little house, which has 5 clips. And guess what? The math works better. That tiny little house is only about $5. And all they did was switch in their tray to adding the reusable clip applier. Again, this is just something that makes sense. We're not asking anyone to change their practice. We're saying, look at your practice and what can you change and do the same operation. They saved $100,000 in 1 year just in changing this lumpectomy practice. We all got to pad our patients in the OR. We got to pad them for long cases. We got to pad them when we put them in uncomfortable positions. They're not awake. They can't move around. And so patient positioners are really important. And sort of the go-to for us has been yellow foam. Do you guys use this here? You guys have it? Sometimes egg crates? Yeah. Okay. Maybe a different color, but same concept. So it's easy to use. It's readily available and requires no cleaning because it just goes into the landfill. And then interestingly, after it goes into the landfill, egg crate never breaks down. It's so interesting. You could dig it up 100 years from now and it'd still look like perfect egg crate. That's not a good thing. So we have gel products. They're not widely used because it's just easy to grab that yellow foam, tear it, put a little piece here, put a little piece there. Well, one of our clinical nursing leads said, you know what, this is not a great use of yellow foam. And so he said, let's go ahead and try just buying less. And he went back and looked at how much we used in 2023. And these are our baseline numbers. You can see, and I gave you some different things here. This is 21 California grizzly bears worth of trash just at a single hospital system. And this is really a picture of one of our dock guys pushing the yellow foam to the dock. He did that 123 times per year of just yellow foam. So let's decrease the work on our hospital workers too. And so he said, we're going to cut use by at least 10%. That was the goal. And he said, let's buy a lot less. And that's how we'll do this. And so before he did that, he said, I want it to be safe, which is really important. We need to make sure our changes are quality changes and safe changes. And so he looked at the pressure at each of the sites, and the disposable foam is on the left there. And hopefully you can appreciate there's a big red dot in the middle. That's right over your olecranon. That's actually what we're trying to pad with our padding. So he looked at the reusable, and there was actually less pressure on that. So he implemented that change. And here you can see in the red line and the blue bar, the significant drop by the end of the year. It took time for people to catch on, but you can see the significant drop in use and spending. And how did it change? You can really see the reduction here. And I said it was 21 grizzly bears, California grizzly bears, but I found out that California grizzly bears and Canadian grizzly bears are exactly the same. It's the same species, and really decreased that amount of waste that went to the dock. So just thinking about patient positioning, we all want to pad our patients. We need to do that. But these are just some of the ways that we can make slight changes to what we're doing and use reusable options all the time. I've done this work with lots of people. This is a picture of some of them. I would be totally remiss not to say thank you to them and really give them the credit for this work. I'm up here talking to you about it, but this is a team effort, and it's across specialties. There are anesthesiologists up here. There are orthopedists up here. There are scrub techs. There are circulating nurses. There are administrators. There are general surgeons. So it's really been great to work across systems and to meet lots of new and interesting people across the hospital. I want to talk about the changes you can make in the operating room. These are things you can do today when you move into the operating room here in just a few minutes. Turn off the water when you're scrubbing in. Avoid unneeded instrument processing. Really say, hold on that if you're not sure you're going to use something. Limit the waste you throw into the biohazard bag. Yes, throw the appropriate waste in there, but if not, move it to the right bag. And you can do that change in your clinic too. Reduce waste in the OR. If you only need one of something, don't open 10 just in case. You can have them on the back table. We can take a second and open them if needed. Assess the need for single-use disposable items. I think that clip applier is a great example of a time that we can all do that in our practice. And then choose local or regional anesthesia if appropriate. In your clinic, I didn't talk much about our clinic work today, but I wanted to say that we can make changes in our clinic too. You can consider a telehealth visit for your patients that travel a long distance. Multiple studies have shown what an impact that makes, both on patient satisfaction. They love not coming to see us, and then also on just the environmental impact of driving. You can reduce paper use. We, have everything at our fingertips, on our computers, on our phones, so we don't need as much paper. Sort our waste when we're doing clinic procedures. Avoid pre-made kits. If you are doing a clinic procedure, they often have excess supplies in them. Use reusable gowns, drapes, and instruments whenever possible. And then if you do have minor procedures that you're currently doing in the operating room, work with your team to say, could I do this minor thing in my clinic or in a procedure room? That really decreases overhead from energy, greenhouse gas emissions, and waste. So I invite you to join us. We are really trying to think about this both on the small scale and on the large scale. Our goal is really no waste, net zero emissions for scopes 1, 2, and 3 by 2050. And, we're checking in every month saying, where are we getting to on this goal? And it seems like 2050 is really far away, but it's the changes we make in 2025 that are going to allow us to meet those goals. So, sometimes this seems overwhelming, but I will promise you that it is really a small group of people that are going to start making this change, and you could be one of them. And then I hope that can have a ripple effect. And as you start talking to your colleagues about this, you can say, oh yeah, that's a change we can make. And just one person becomes 2, becomes 10.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.